Good afternoon, colleagues. I'm Burt Rochelson from Northwell Health System in New York. First, I want to congratulate Dr. Eva Chalice. I had the good fortune to work with Eva early in our careers at Stony Brook, and now you all share the good fortune of working with her going forward. And as our leader, I'm proud of ACOG for making such a wonderful choice. I think that we were chosen to present this because of our unfortunate location, which is right in the heart of the epicenter of the COVID-19 crisis. I thought it would be best to look at this in terms of the different periods of time in pregnancy. And so we're going to examine how our health system, which is quite large, as Dr. Nemiroff discussed, in terms of our strategies during prenatal labor and delivery and postpartum periods. I'd like to address the lessons that we learned from this, sometimes the hard way, in terms of adjusting our guidelines, our practice, the way we deliver care, the way we communicate to patients and staff, and really being forced to make remarkable changes in a very short period of time of about a month. I also think that many of the lessons that we learned will prove to be valuable even after the crisis has abated, may it be soon. So we mentioned already that Northwell delivers over 30,000 babies a year, and this varies between 350 at a hospital to 8,000 per year at another hospital. There are a number of tertiary care hospitals in Northwell and also a number of smaller community hospitals. The first two cases of COVID-19 were only reported on March 3rd. And so over a period of 4 to 6 weeks, we've seen dramatic changes in the way we provide care. I also want to point out that our hospital system is really both demographically and geographically diverse. Long Island, for those of you that don't know, is long, and Riverhead Hospital is way out here at the very edge of Long Island. And we also have hospitals in northern Westchester, suburban area, and hospitals right in New York City, in Manhattan and in Queens. So we were tasked with creating protocols and guidelines that would meet the needs and the scope of all these hospitals. Part of our challenge was really to address the fact that there are two epidemics. There's the epidemics of the virus itself and the epidemic of fear. And it's also very challenging to address the epidemic of fear. And I think one of the ways that we can look at this and how I discuss it with patients and particularly my staff is that usually when we talk about the tip of the iceberg, we talk about something bad that's happening at the top and all of these worse things that we can't even see. And this is really in a lot of ways the opposite. And that's why I call it the iceberg of the tip. The media and our hospital systems are focused, understandably, on the terrible cost of deaths and really severe disease in the patients in our community and the impact that has on staff. But we all know that there's this huge part of the iceberg that's harder to see, especially since there's not widespread testing of asymptomatic, or I think the right term in many cases is pre-symptomatic or mildly symptomatic cases. So addressing this difference is really essential in the way we communicate with our staff and also with our patients. In terms of the prenatal period, it became clear that our main objective in a lot of these time periods was to reduce the number of visits to the hospital or to our offices, and also to reduce the number of encounters with any individuals, either in the hospital or the office. And the way we approached this was by reducing the number of prenatal visits, the number of obstetrical ultrasounds and antepartum testing procedures, and we created our own individual protocols for our institutions, keeping in mind, of course, maintaining safety for patients and staff. We used as a template some of the excellent articles that very quickly came into the literature at the beginning of the crisis, some by Bolig et al., also using guidelines established by ACOG and Society of Maternal Fetal Medicine. And just to give you an example, we spread out our obstetrical visits by using telehealth for the initial visit and for postpartum evaluation, and eliminating some of the visits in the middle of the pregnancy if they weren't absolutely necessary. We also found that if we could have visits for antepartum testing and ultrasound coincide with the prenatal visits, we could reduce the traffic in and out of our offices, and also be able to enforce social distancing within our waiting rooms. Many of our practices would have the patients wait in the car until they were ready to be seen, and they were called on their cell phone to present for their visit. And that actually worked very well, and patients were satisfied. We altered our protocols for ultrasound in pregnancy so that if somebody had had a dating ultrasound earlier in the pregnancy, they were given the option of having non-invasive prenatal screening and avoiding, in many cases, the ultrasound for nuchal translucency 11 to 14 weeks. If the ultrasound for the level 2 or fetal anatomy scan was suboptimal, we would have the patient return, instead of a week or two, have them return a little bit later, so that we were more certain we would have an adequate exam at that time. If patients had a BMI over 40, we would try to schedule their anatomical survey at around 22 weeks. It was our practice in our units to do transvaginal ultrasound for cervical length at 20-week ultrasound, in the interest of reducing the traffic and time spent in the hospital. And in our prenatal diagnostic units, we began to do contingent screening, that is, do transabdominal ultrasound and do a transvaginal ultrasound only if the cervix was thought to be short on transabdominal ultrasound, or if the patient had historical risk factors. This was published in ACOG MFM as a way to spread out ultrasounds based on the diagnosis of the patient. And for the most part, the principle is that if we could do our serial ultrasounds at 6 weeks rather than 4 weeks, it was preferable to do so. And we followed those guidelines as well. Antepartum testing, again, the principle was to do fewer tests, but still maintain the safety for the patient and the fetus. And we put a lot of thought into developing our own guidelines. This is from one of the ACOG MFM journals. In principle, when you could do a biphysical profile rather than a non-stress test, that was preferable, as the average time for biphysical is less than 10 minutes, and non-stress test requires, by definition, over 20 minutes of screening. As mentioned, we tried to combine them with office visits, and we looked very hard at all of the indications, and whenever possible, we would do the testing at a weekly basis rather than twice weekly. And of course, these have to be individualized based on the patient's gestational age and unique presentation. Because our hospitals became primarily COVID hospitals, just to put it in perspective, one of our tertiary hospitals is a 900-bed hospital, and it over a matter of a couple of weeks became 90% COVID. So our hospitals became COVID or obstetrical, which was certainly represented unique challenges. Many of our patients preferred not to go to the hospital for their antepartum testing if avoidable, and frankly, the hospital needed the space that we were occupying. So in the middle of March, we took our entire prenatal diagnostic area out of the hospital and moved it to a private office. To put that in perspective, we do about 40,000 prenatal diagnostic procedures, including ultrasound invasive procedures and non-stress tests annually. So it was quite a heavy lift. We accomplished it in a couple of days, and now it's running quite smoothly. One of the ways we were able to do this was to really use the telehealth programs. Interestingly, we had discussed using telehealth prior to the start of the pandemic, but this really accelerated us embedding this into our practice. And since the start of our telehealth, telemedicine program, we've done over 300 consultations by telehealth or telemedicine. And I have to tell you personally, I love it. The patients seem to love it. And in a lot of ways, it's a more personal, more face-to-face interaction than seeing patients in your office. And it also eliminates driving to your office for the patient and waiting in your waiting room. I think this is another area that we may have learned the lesson and hopefully continue this as a significant part of the way we practice obstetrics and maternal fetal medicine going forward, even after the crisis is over, maybe soon. Strategy for labor and delivery and triage was also driven by the principle of reducing traffic, reducing unnecessary encounters, and trying to triage COVID positive from COVID negative patients. This also relates to what I said at the beginning of this talk, which is we also had to continually deal with the issues of fear among our staff and among our patients. And one of the ways we did this at the beginning of April was to institute routine PCR screening for COVID-19 for all patients that were coming in for delivery. One of the reasons we felt this important was that contacts and travel history were really no longer as significant as they had been before. We knew that there was COVID in our community, in our particular communities. It was very, very prevalent. So travel history was not significant. And once we knew there were a lot of asymptomatic carriers, contacts became less significant. So we needed a rapid test, and it needed to be done on site. And we were able to provide these patients. And it was challenging because we still did not have enough tests, but we got the assent of the hospital administration to do testing on all patients presenting with a rapid turnaround. For patients that were scheduled to have cesarean sections or inductions, we tested them 24 hours before, so by the time they presented, we already had their results. This was a tremendous staff and patient satisfier and has really allowed us to deal with some of the negative energy, especially in the early part of the crisis where it was very challenging, understandably, for everybody that was on labor and delivery. Having the PCR results allowed us to identify who was COVID positive and cohort the COVID positive patients separately. I want to just say one word about the semantics we use about calling patients asymptomatic. I think in many cases they're pre-symptomatic. There's not a lot of longitudinal data, either in pregnancy or outside of pregnancy, about this. But I'm always a little cautious when I use the term asymptomatic because we know that this disease may have a long course, and many of these women may be pre-symptomatic. These are some early results that are yet unpublished, but just the first week of our screening program. As mentioned, we have a very large obstetrical practice, so in the first week we did 300 plus patients. Our hospitals are different demographically. As I mentioned, North Shore University Hospital is in a largely suburban area. Long Island Jewish Medical Center is more of an urban patient population demographic. At North Shore, we found 11% positivity rate among universal screen patients, and at Long Island Jewish, it was 22% in that more urban environment. However, interestingly, more of the patients at North Shore Hospital, the more suburban hospital, were symptomatic when asked about the presence of symptoms. Visitors on L&D was quite a controversial area for us. Some of the hospitals initially in the metropolitan area did not allow visitors even on labor and delivery until sometime later in March. This was mandated by both the governor of New York State and the New York State Department of Health, which required hospitals to allow one visitor, if only for labor and delivery. And it's our practice that the patient must leave in the immediate, the visitor must leave in the immediate postpartum period. I'll get in a minute to when the patient must leave. On March 21st, we converted to a Laborist model, which was a major change for the practice paradigm in our hospital, which previously had been a hybrid between full-time faculty and voluntary obstetricians in solo group practice, who historically would deliver their, quote, own patients. So in order to reduce the traffic in and out of labor and delivery and to reduce the number of personnel on labor and delivery, a team was developed of laborists, which included both full-time and voluntary faculty, and the number was 42. It was interesting because all of us were talking about social distancing, but when there are 12 or 14 people in the labor and delivery lounge, it's impossible to socially distance. So I think this was a very valuable response to that. Also valuable was that this group delivered all patients regardless of insurance status or where the prenatal care was given. And apparently this is very well received by both patients and staff. It reduced the on-call frequency for the obstetrician, and just fortunately it coincided with redeployment of our residents, fellows, and other staff who were pulled from our obstetrical service to serve on COVID wards. This is another area that I think may have applicability even after the crisis has abated. The route of delivery of mothers with COVID-19 should be based on clinical circumstances and not on the presence of COVID-19 itself. Early on, we dedicated a cesarean section room for COVID-positive women. However, and we've certainly seen this in our institutions, the 10 hospitals at which we deliver obstetrical care. In critical situations, urgent delivery and early delivery may be required both for maternal or fetal indications. One of the other areas that we had to develop a strategy for was the concern that the second stage itself may result in forceful exhalation and reduce the efficacy of patient face masks. And so we early on required full personal protective equipment for COVID-positive laboring women. And I want to thank ACOG and SMFM for their support in a letter to CDC on March 31st, advocating the importance of using the appropriate PPEs in the second stage of labor and delivery. The mode of delivery, there's no contraindication to vaginal delivery. The circumstances obviously will drive this decision. One should consider the extra time necessary to don a PPE and to prepare an operating room for emergency surgery. If emergency surgery for delivery is planned, you have to consider cesarean delivery at the bedside in the ICU, both because of its urgency and to avoid transferring the patient. And so when we have patients in the intensive care unit, we have a cesarean tray ready to go in the intensive care unit. The timing of delivery, COVID-19 does not mandate early delivery. As I mentioned, the disease may have a long course. So if you have a patient with relatively mild disease and it seems like she's improving and she's not quite near her due date, it's reasonable to attempt to postpone delivery until either she gets a negative result or the quarantine period has ended. I would mention that we've all seen that the disease can worsen in the second week, so it's very hard to judge when delivery should happen. The next box here in the southeast, where I say consider timing delivery at 34 weeks, there's really no data in the literature of this. It's interesting, the other thing that's evolved during this crisis is where we get our information. There are social media sites like Instagram where people that have experience with pregnant women with COVID-19 share their experiences and thoughts. I find it very interesting to see this, but we have to exercise caution that we don't drift into what I call Facebook-based medicine. However, there's not a lot of evidence-based medicine to sort of inform our decisions about specific cases. Postpartum care required a particular challenge. On early March, we began a process of discharging all women with vaginal deliveries at 24 hours and those with cesareans at 48 hours. We developed a set of checklists based on criteria which were written by obstetrics and pediatrics to provide safe early discharge for mothers and babies. We had our home care units participate in this, and there are postpartum phone calls, and we are developing a postpartum telehealth program, which again may prove to be very valuable even after the crisis is over. However, there was such demand for our beds, so much demand that on March 23rd, we had lost many of our postpartum beds. We went from bed capacity of 73 to 13. And so we were required to move our postpartum patients to a separate facility on our hospital campus on March 23rd. COVID positive patients are in a cohort area in the main hospital, so only patients that were COVID negative were transferred. And this has worked out really quite well. And again, I was humbled, inspired, impressed with the way our nurses and doctors worked together to make these changes in a very short period of time. And our engineering staff in the hospital was able to build these facilities in a very short period of time. When I say build, I mean outfit. For example, we went to an ambulatory surgery center, which was retrofitted to take our postpartum patients. I want to say one word on the semantics of this issue of COVID positive. I think as we're entering hopefully soon the phase of antibody serology testing, we should be specific of what COVID positive is, because it makes a difference. I think we should look at using the terms COVID PCR positive or COVID antibody positive, because I think we'll find that we could worry a lot less about COVID antibody positive. And I would encourage all of us to use the appropriate semantics for COVID positive. I want to again congratulate my good friend and an amazing doctor, an amazing leader, Dr. Eva Chalice. And I'm just going to share with you what I tell all my staff and my family and my friends. I don't know when this is going to end. I don't know how long it's going to last. I just don't know. But this I know, we're one day closer to the day it's going to end. Stay safe, everybody, and thank you for inviting me to speak.